Hello, hello, hello. Good evening, students. Good evening. Welcome, all of you. Am I visible to all? Am I audible to all? Yes, good evening. Uh, Praniti 26, good evening. Yes, and welcome, all of you. So let us begin. Just a second, all of you. Yes. So quickly settle down and yes, okay. Very good. Excellent. Praniti, perfect. Yes, good evening. It's a Sanskrit. Yes, excellent. Okay. Chalo. Welcome, all of you. And I think the audio video is all clear. And yes, ठीक है चलो start. So very important session for all of you, and I want all of you to participate in the session. Right, wrong does not matter. What are we here for? Okay, we are here for the final D-Day live most repeated PYQs as well as the most expected PYQs. Okay, all of you surely you'll remember me on the day of the exam. All these questions are surely going to come in the upcoming examination. Okay, so let us begin. And before that, those who haven't yet subscribed to the YouTube channel, please take just 10 seconds, subscribe to the YouTube channel so that you can do the live chatting. Also, follow us on Insta and follow us on the Telegram. Also, the PDF will be available on the Telegram very soon. Yes, definitely, beta. Okay, and do not forget, please download the OGGuru app. Like today, what session we are going to have? We had a super session three last week where we have three important sessions, most important IBQs, clinical cases, and expected PYQs, and this is just 199. I want all of you, it will just take you 4 hours. You will be able to revise the entire OBGY in 4 hours. It's the fastest way, and trust me, dear student, your score in OBGY is tremendously going to jump up, and all of you are going to do very well because it's a single most important subject. 30 to 35 MCQs are going to come. So I want all of you, just 199 rupees. There are three sessions and which you can see at 1.5. Just in 4 hours you will be able to master the entire and the most important. Okay, now chalo start. Whenever a IBQ comes, what will be the mode of delivery in this case? Question has been given to you. Very important MCQ, very important image based question. Anybody? So I want all of you to answer. Right, wrong does not matter. I want all of you to answer. Yes, chalo start. Yes, it's a, like a revision, but bacha, but if you've seen the app videos, excellent. If you attend, it's good. It's optional for you, beta. Yes, great. Chalo, now A, B, C, D, A, B, C, D. Now, whenever an image-based question comes, students thoda sa panic ho jate. Don't panic. First, see. Take 10 seconds. Takes 10 seconds to observe the picture. Okay, somebody saying A. Okay, somebody saying A. All of you, A kisko? A hai, B hai. Okay, so now first of all, what you have to see in the picture, okay, so there are two separate placenta. This is one placenta, this is another placenta. So there are two separate placentas. There is also a dividing membrane between the two. So what kind of a twin it is? It is DCDA, dichorionic diamniotic. Now tell me, who is the first baby over here? इसमें first baby कौन सा है? The one which is above or one which is down? Yes, sir. The one which I feel on PV examination is the first baby. So this is the first baby. And what is the position of this first baby? Yes, sir. The first baby here is in breech. The second baby, this is the second baby who is in vertex. And what is the rule, my dear student? Anybody? Rule kya hai? Yes, sir. That if the first baby, always the route of delivery is decided by the first baby. And I repeat, the first baby is the one which I feel on the PV examination first. Is this understood to all of you? And therefore, perfectly correct. What is the rule? That sir, if the first baby is non-vertex, first baby is non-vertex. By what do I mean by non-vertex? Let it be anything. Let it be breech, brow, face, oblique, transverse. We will do LSCS. But one more thing, all of you. So when the first way, now see how the question will get changed. All of you look on this and very interesting. देखो एक के साथ एक image free. Now here tell me what will I do? Another picture. Is it the same picture or different picture? Are both the pictures same or different? This was first picture, this was second picture. Now tell me this. Anybody? Anybody? Yes. Sir, now here the picture is rotated. Sir, here now the first fetus is head down. This is vertex. And second baby, the second baby is in the breech position. Second one is in the breech. So here, sir, what it is? We will try vaginal delivery. Is this understood to all of you? Clap. And this is two separate placenta. You can see placenta. So this is dichorionic diamniotic twin. But one more MCQ. One more so that your entire twin management revived. So here, sir, this is first baby is in breech. Sorry, the answer vaginal delivery is not possible. You can't apply forceps, and ECV is not to be done in twins or multiple pregnancies. Is it clear to all of you? Remember this. External cephalic version is contraindicated in your twin or multiple pregnancy. Is this understood to all of you? But now suppose one more difficult question I give you. Suppose if I tell you okay, it is, all of you look on the board. Sir, first baby is also vertex, second baby is also vertex, but it is MCMA twin. What will I do? Chalo, very difficult virgin MCQ. Yes, beta, mama, you tell me if one placenta. Is it clear to all of you? If one placenta, what will I do? Is it clear to all of you? Yes. So please understand this. Yes. If one placenta, what will I do? Yes. So please understand this that sir, once it is MCMA, do not even look at the baby's position. Once it is MCMA, MCMA always goes for LSCS. Why? Because sir, very high risk. Moment I rupture the membrane, very high risk of cord prolapse, and during labor, both the cords can get intertwangled among themselves, cord entanglement, both babies can die. So clap if you have learned something new. MCMA will always go for LSCS. Thoko tali. Is it clear to all of you? So I repeat, okay, the rule, this rule, okay, I will see the first baby position. This rule is for DCDA and MCDA twins only. Is it clear to all of you that first baby position, first baby ka presentation or position check, okay, depends on the presentation of the first baby ka you check this check, and if the first baby is non-vertex, it will go for LSCS. This is for DCDA and MCDA only. And I will write down over here, if the first baby is vertex, then yes, you try VD, try vaginal delivery. Is this clear to all of you? But that is only for DCDA and MCDA. Chalo, superb, excellent. Moving on to the next. Kya hai ye? Again, a very important question. Surely you will remember me on the day of the exam. First, ye kya modality diya hai? Anybody? What modality is given to you? Is this a USG? Is this CT scan, MRI? This is what? So this is a X-ray, and it is a contrast X-ray. Please comment which day of the cycle this is done. And what is this? Yes, sir. This is hysterosalpingography, HSG, hysterosalpingography. Which day of the cycle we do it? And first I will show you the normal. Clap if you feel happy. So sir, normal uterine cavity, sir, normal uterine cavity, triangle, okay, then it is completely opacified. There is no filling defect. It is a perfectly triangle, just like a wow. See this, okay, it will be perfectly opacified. Very good, no filling defects. And then thin bouncy wavy tubes, thin bouncy wavy tubes, and then we get the spill of the dye, isn't it? And can you tell me spill is normal or not? Yes sir, the spill is absolutely normal. So this is a normal HSG. This is a normal HSG which I have shown you. Very good. We do it on the 9th day, 8, 9, 10 day. Very good. But now all of you look on the board here. And what is the instrument? That also you tell me. What? There's an instrument with which you push the die. What is the name of the instrument? Okay. So now this is normal. But now please pay all of you. When I look at this, I can see the tube. Can you see this tube? Yes. I can see the tube very well. I can see thoda sa spill also. This is also the tube. That is not a problem. So it is not a bilateral cornual block. How will the bilateral cornual block look like? I will tell you in 2 minutes. Again, a very important image. This is not a bicornuate. This is not a normal. Focus on the center. Sir, when I focus on the center, what are we seeing? Yes, sir. We are seeing multiple filling defects. There is all kachra. Can you see this kachra? Matlab there are lots of adhesions, which is our Asherman syndrome or intrauterine adhesions. What is the management also will discuss. So basically, this is suggestive of this HSG is multiple filling defects. Multiple filling defects. Is this understood to all of you? Multiple filling defects suggestive of Asherman syndrome. Anybody, why do we get it? Why do we get it? Okay, so it is like this. Okay, it is like this. Okay, so because of this crisscross appearance, we are seeing multiple filling defects. It is multiple filling defects, which is suggestive of intrauterine adhesions. Okay, intrauterine adhesions or multiple filling defect. Is it understood to all of you? Yes. Okay, yes, because of repeated curettage and multiple curettage. Is this crystal clear to all of you? Now, can you tell me how will a bilateral cornual block look like? So one more important image. Sir, bilateral cornual block will look like this only. You will just see the triangle. Tubes are not seen. Okay, so if only a triangle is seen, and that is your bilateral cornual. Okay, now very, very important. Chalo, tell me this. This is again surely coming in this year's exam. Again an image. So we're starting with so many images. Your images will become perfect. Okay, is it clear to all of you? And those who haven't yet enrolled, please enroll in this just 199 rupees OBG booster course and tremendous benefit in your preparation. Yes, chalo, tell me now. What is this picture telling you? Blue, 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 blue. Okay, so now moment. Mistake what student make, because I can predict. Moment, yes, A, all of you. A kisko bolna hai? A, yes. Because sir, what is all this blue, blue dye? Methylene blue dye. Wrong. So moment the student sees the methylene blue dye, they will see this methylene blue dye and mark this as the answer, but it is wrong. Why? Because this is not a hysteroscopy image. Clean bold. So what is it? Of course, this is not a USG. USG is all black and white. HSG I have already shown you. This is laparoscopy. Why am I saying this is laparoscopy? Sir, this is the uterus. We are seeing the view from above. This is the pelvis and the pouch of Douglas. Can you see this? This is the ovary. So I'm labeling it and showing you. This we have held the fallopian tube. Okay. And this blue color dye, what we are seeing is, yes, the methylene blue dye. That is the spill of the dye. What is the dye used? Yes, sir. The dye used is methylene blue. That is an important MCQ. Same picture, same thing. This is the uterus, this is the uterus, this is the tube, this is the pelvis. So now please understand this. What it is, what is this is, please keep in mind. Yeah, this is the uterus. Okay, this is the pelvis and the omentum, what we are seeing, and this is the tube. Okay, both pictures are showing you the same thing. So what is this? Yes, sir, this is laparoscopy chromopertubation. And what is the speciality of this? So this is the gold standard or the best investigation for tubal patency. Ek pe ek MCQ free. Are you getting this? How important things are? One MCQ free. So if they ask you any problem on HSG, please confirm it by doing a laparoscopy chromopertubation. Very quickly, I will tell you what is done in this. All of you look on the board. Sir, we are putting in a telescope from above. Okay, we are putting in a telescope from above. So you will see everything from above. Okay, and this is the fallopian, this is the uterus, this is the fallopian tube. You'll see the ovaries also, and the assistant. What is the name of the dye? Yes, sir, methylene blue dye. The assistant will put the dye from the cervix. Assistant will put the dye from the cervix, and the dye will enter the tube, and dye will come out of the femoral end. Everybody starts jumping in the OT. Blue hai pani, pani, clap. Okay, blue hai pani, pani. So this is also the spill of the dye, and this, my dear student, is called chromo, means color, Pertubation means to do put it inside the fallopian tube. So yes, it is done with methylene blue, but don't get confused. Hysteroscopy ke sath we never do methylene blue. Is it clear? With hysteroscopy, there is no indication of doing methylene blue. Hysteroscopy is for seeing the cavity of the uterus. We'll discuss all that in some time. These are very important MCQs. So, sir, this is a laparoscopy, chromopertubation. Is this clear to all of you? Yes. Can I get yes? Yes. Now, chalo. Again, one more thing. What is this? So, lots of this. Again, a PYQ. Again, a PYQ. Very likely to be repeated. What is this? So, this is a cervix shown to you. This is a cervix. This is the anterior lip. This is the posterior lip. Okay. And what it is that, sir, in early pregnancy, yes, sir, it is a dusky or a bluish discoloration of the cervix and the vagina also. And this is the Chadwick sign. Chadwick sign. Is this crystal clear to all of you? Okay. Osiander sign is the pulsations when I do a PV examination. Okay. Osiander signs are the pulsations in the lateral fornices. Okay. Okay. Osiander sign is the pulsations which you feel in the lateral fornices. Okay. So that is the Osiander sign. Pulsations. Okay. And Yeager sign is what? So on bimanual examination, approximation of the finger. Okay. Yes. Okay. This is approximation. Goodell sign is what? Goodell sign is what? हाँ बेटा सेहत सकाफी से एकदम फास्ट करेंगे. Okay. थोड़ा सा समझना भी चाहिए बच्चों को. Yes. Goodell sign is what? Yes, sir. Cervical softening. So all the signs we should know. Cervical softening is the Goodell sign. Is this crystal clear to all of you? No, there's my mic. There's no problem with the mic, beta. Mic is all okay. Okay. No, there's no mic problem. Hello, hello, hello. There's no mic problem. Hello. Yes. Now, chalo, tell me. Blue cervix, uske baad what happened? Okay. Yes. Chalo, now tell me. What is this picture showing you? This whole picture is looking what in color? Sir, this whole picture is looking green in color. So, kitna hai sir today? What is the day? Today is colorful cervix day. Today is colorful cervix day. Okay, today is colorful cervix day. First was bluish discoloration. Okay, bluish discoloration of the cervix and the vagina. Now this is what? Yes, sir, this is again a very important virgin MCQ. This MCQ has been asked, but virgin image. Yes, this whole cervix we are seeing is green in color. So it is whose cervix? It is cervix of who? It is cervix of Lady Hulk, She Hulk. Yes or no, student, tell me. या किसका? Gamora. So this is cervix of She Hulk or Lady Hulk. Arey no, Baba, no, not like that. Yes, sir. This is colposcopy. This is not a pap smear being taken. I will show you today only. This is not a liquid-based cytology. Liquid-based cytology, you take a cytobrush. I'm going to show you the picture in some time. This is not a hysteroscopy. Hysteroscopy, we enter into the cervix and see the cavity of the uterus. This is colposcopy, and colposcopy specifically with green filter. Green filter is a PYQ. Green filter is a PYQ, but this image is a virgin IBQ. It will come in the exam. Now the green filter, yes, Hulk is very good. The green filter is for what, my dear student? So the green filter, so it's a colposcopy. Green filter is to see what? Again, a very important MCQ. So just a green color light, we use a green color light. So green filter is to see the blood vessels. Please keep that in mind. Again, a very important. So please understand this. With every MCQ, I'm teaching you extra 2-3 MCQs. So green filter is to see the blood vessels better. Okay, we can see the blood vessels better with green filter. Okay, so again, cervix, ye anterior lip, posterior lip, whole cervix is bluish in color. Chalo, now tell me, this is again a short MCQ. Okay, again they will tell you, identify this ultrasonography of the uterus. And when you get a MCQ, you look at all the options. You will definitely come to know this you will definitely come to know the answer. Okay, so here what it is, my dear student. Yes sir, this hole is the uterus thing, this hole is the uterus, and we are seeing what? Multiple fluid filled grapes like vesicle. Yes, so this is what? Why is it not? Oh, obviously sir, OHSS to is in the ovary. OHSS picture you see in the ovary. Adenomas is not as, yes, this is a complete vesicular mole or V mole. This is the famous snowstorm appearance. Last FMG, there were two questions on this topic. Also, please tell me what is the management. Okay, so complete vesicular mole. So what is the difference? Anybody? Complete mole and partial mole. So complete fluid filled grapes like part. All the chorionic villi are filled with filled with grapes like particle, which is called as the typical snowstorm. In partial mole, sir, we also see the baby part. So baby is playing with the snowstorm. Is it clear to all of you? One more MCQ. Chalo, tell me the karyotyping. दोनों का karyotyping बता देंगे. What's the karyotype for complete and partial mole? Anybody? Complete mole, what's the karyotype? Partial mole. So every MCQ is important. Yes, and management is very good. I have to suck out. It's a suction evacuation, whatever may be the size of the uterus. Is it understood to all of you? Whatever may be the size of the uterus, it has to be a suction evacuation. Very good. Complete mole 46XX is the most common, and partial mole is always a triploidy 69. Very important MCQ. Keep this in mind. And it is suction evacuation. Whatever may be the size told to you, 16 weeks, 18 weeks, 24 weeks, it is always suction evacuation. And one more important MCQ. After sucking out, what do we monitor? After sucking out, what do we monitor? Again a PYQ. Again a PYQ. In a vesicular mole or a complete mole, after sucking out the pregnancy, what do we monitor? Yes sir, we monitor the HCG levels, and the HCG levels has to keep on coming down, coming down, coming down. Is this understood to all of you? So complete mole में sir, this is the famous snowstorm appearance. Partial mole में I see fetal parts. And anybody, radiology MCQ, how will the adeno? Very good. All of you. Manish Manju, Satyam Shukla, Harish Sami, all of you correct. Mohammad Asif, A Life of a Doctor, all of you correct. Now, chalo, last. Very difficult, PG level. Adenomyosis कैसे होगा बता दो. Adenomyosis, how it will be? So, sir, adenomyosis, we will see glands. In adenomyosis, sir, we will see glands within the myometrium. You will see cystic spaces. Glands within the glands will be looking like cystic spaces. Okay, cystic spaces within the myometrium. Within the myometrium. And what is it typically called as? Yes, sir. Venetian blind appearance. Venetian blind. Yes. Venetian blind, salt and pepper. Uterus will be bulky also. Uterus, it will be a bulky uterus. Okay. And remember, posterior wall is more affected compared to the anterior wall also. Okay. Uterus will be bulky, and muscle ke under glands. Yes, symmetric. Yes. But yes, very good, Harish Sam. Okay. Venetian blind appearance. Chalo. Now again a super MCQ. What is this instrument, and what is the use of this instrument? Clean bold. Many students get clean bold when they see the instruments. Okay. Yes, this is what? This is what? What is the name of the instrument? Yes. So this, my dear student, please pay attention. When you see it's a long instrument, there is a triangle. Can you see a triangle at the end? Can you see a triangle? Yes, sir. This is a green Armitage forceps. What is the name of this instrument? Very important virgin MCQ. It's a green Armitage. So where do I use it? Yes, sir. All of you look on the board. So this is the uterus. I will make a cut over here during LSCS to get the baby out. Now, of course, I am suturing it. But before I suture, all these angles, and the edges are going to bleed. Of course, I have made a cut. So till the time I suture, no, it's not Alice better, wrong, clean bold. Alice nahi hai, clean bold, wrong. So here I apply this green Armitage forceps, So this triangle part, can you see this triangle part? Yes, the triangle part will compress the vessels, and then of course the instrument is like this. The triangle part is to compress the vessels, okay, and the angle. So it is to hold the uterine edges and angle in LSCS. It is not used in tubal ligation. It is not used in dilatation curettage. It is not all of the above. Is this understood? So very important tough MCQ. This is green Armitage forceps, and it has got one and only one use in the OT table at the time of cesarean section, before I suture the angles. Of course, then I start suturing, and when you start suturing it, then you will obviously remove it. Okay, so once you start suturing it, you remove it, so that till the time it is temporary to control the bleeding. Is this understood? Clap if you have learned something new. OG in the chat box. Is this understood to all of you? Yes. Now chalo, tell me, what is this showing you? Is this understood to all of you? Yes. So two things are shown to you. This is the air spatula. Air spatula. Okay, air spatula. This is going in the posterior fornix. This is to rub on the cervix, and this is to do a pap smear with a glass slide. You will put it, and you will put it on the glass slide. And this, my dear student, I told you I will show you. This is a cyto brush. Can you tell me? The cyto brush is rotated, and what is this? So this is a liquid based cytology. LBC, clap. Yes, cyto brush to do a liquid based cytology. What is the advantage? Anybody? Okay, so the cyto brush, we rotate it onto the cervix, and this tip only, this whole thing is then dipped in the liquid, removed and sent for testing. What is this? What is the advantage of liquid based cytology? Is that I get a much clear picture. We get a clear picture. And over and above that, today with LBC, what can I do? Sir, I can do HPV testing. Yes or no? Absolutely. Virgin MCQ, difficult MCQ. We can do HPV testing as well as HPV typing. HPV typing. That means what? Today I can tell the patient that you are infected with HPV 16 number, 18 number, which number. So I can tell the patient whether you are HPV positive or HPV negative, and if you are positive, I can tell you which number also HPV the patient is affected. For that, compulsory LBC testing has to be done. Is this understood to all of you? So cytobrush, LBC, sure short MCQ this year. You will remember me on the day of the exam. Very, very important MCQ. Again, a clinical case. Okay. So all kind of MCQs we are going to cover today. As I said in this session, I've shown you images. More images are going to come. Stay right till the end. And this is clinical cases also. The one-liners also. Okay. And yes, chalo, tell me. Chalo, tell me the answer. Yes, 19-year-old unmarried girl is primigravida, presents with 45 days, wants MTP. What do you do? Okay, so here what the student think, many students, sir, the girl is unmarried and therefore inform the police and MTP contraindicated. Wrong. Okay, please understand this. That's not the case. As long as the girl is major and she is of a sound mind, she can give a consent for MTP. MTP is not contraindicated, and I don't have to inform the police. When do I have to inform the police? Yes, sir. If it is a minor girl, because you know the POSCO Act, if it's a minor girl, if they tell you 17-year-old, 16-year-old, then even with consensual sex sex is considered rape, and therefore then I will inform the police. Is this understood to all of you? So as long as the girl is major, there is no question of involving the police, and MTP is not contraindicated. Is this understood to all of you? Yes. Now, how is the packet going to look like? Very good. All of you look on the board. It is a combi kit. It is a combi kit. Sure shot MCQ. You will get like this. What is the first tablet? How do I remember? Sir, mifepristone is given first. Clap. How do I teach you? Sir, mifi has the letter F, and first also has the letter F, and therefore mifi is to be given first. Mifi is 200 milligram. How do we give it? Oral, oral, oral. Okay. And after 48 hours, we give misoprostol. Again clap if you feel happy. S, miso में है S, S में है second में है also है S. Is this clear? So lifelong you will not forget, is my guarantee. And misoprostol is what? Yes sir, it is a PGE1 analog. Misoprostol is a PGE1 analog. Each tablet is 200 microgram. Don't make a mistake. You can see totally 4 tablets, so that is 800 microgram is the dose. Either orally or vaginally or sublingual also can be given. Is this understood to all of you? So now jahan pe bhi this is wrong. Why this is wrong? Because meso is written first. Sir, meso is not first. And why A is also wrong? Can you tell me? Yes, why A is wrong? All those who marked A wrong, because the units have interchange. Mifepristone is not 200 mcg and meso is not 800. That is wrong. The correct answer is absolutely correct. Option C, mifepristone 200 milligram and meso 800 microgram after 48 hours. Clap. Is this crystal clear to all of you? So 19-year-old girl can give a consent, absolutely nothing to worry. Yes, and 200 milligram oral is the first drug. Mifi is always given orally I will give, and the meso can happen oral also, or vaginal also, or sublingual also. Is this understood to all of you? Yes. Okay. And of course many students are in touch with me already. You know, thousands of students are in touch with me on this phone and WhatsApp. If you have any difficulty, directly feel free to WhatsApp me on this number. The number is flashing on your screen constantly. I'm personally guiding all the students how to study, how to prepare. Is this understood? Chalo, one more MCQ related to MTP only. 22 weeks latest guidelines. What is the latest guidelines? 22 weeks pregnant lady with occipital failure requesting MTP. What as per the latest MTP Act? So directly student know, yes sir, MTP was allowed till 20 weeks and now it is taken till 24 weeks. And therefore what many students directly will mark, sir, can be done with the opinion of 2 doctors. Wrong. Wrong. Why it is wrong? Chalo, tell me. Why it is wrong? Yes, wrong. Smooth specialist, wrong. Yes, why wrong? Clean bold. Okay, why? Yes. So why? Please understand. Because what it is. Yes. So please understand this. Okay, MTP was allowed till 20 weeks and now the limit is increased to 24 weeks. Yes. But this is increase for which indications? Yes, sir. This increase is if there is a anomaly in the baby, structural problem or a genetic problem in the baby. Is it clear to all of you? Yes, don't worry. Okay, yes. Second is what? Yes sir, if it is some sexual assault or rape, then of course 100% I can do up to 24. So many structural anomaly. Okay, it's a structural anomaly in the baby, structural anomaly or any genetic problem in the baby, then of course I can do it. And yeah, congenital rape. And third is some special, of course, to save the life of the mother. And third are some special situations like what? Sir, suppose divorce during pregnancy, change of marital status. What is the most important take home message? The take home message is, okay, sir, the failure of contraception. Failure of contraception. Okay, if your condom has torn, condom फट गया है, you can't be sitting at home till 24 weeks. Failure of contraception is still up to 20 weeks only. Clap. Very short this MCQ is coming. Short. Okay. So for failure of contraception is only up to 20 weeks. The limit has been increased for sexual assault victim and anomaly. So I cannot do with two doctor opinion. Is it clear? There is no need of permission of hospital superintendent. No. And medical board comes into the picture after 24 weeks. If the pregnancy is after 24 weeks, but again certain anomaly. Okay. When there's an anomaly, then the medical board will decide. Is it clear to all of you? Yes. Why? Because sir, here all of you look on the board. Sir, here the question is with OC pill failure. Is it clear to all of you? So many places wrong answer is given. Please don't follow that. I repeat, sir, here the question is that patient has come to us with OC pill failure. I can do only up to 20 weeks. But yes, by chance if I do a sonography, and if a congenital anomaly is present in the baby, then yes, I can do it. Is this understood to all of you? So permission of medical board, all that does not come over here. Yes, by chance if a anomaly is there, then the indication will change. Is this understood? Yes, clap. Okay, so this is just a trailer. It's just a trailer, my dear student. You will realize when you attend those 6 hours. Then it will go exactly get over in 4 hours only. Okay, is it clear? The OG booster course, so many students had joined live and now the recording is available only in 199 rupees. Is it clear to all of you? Yes. So I repeat, can be done if congenital anomaly is there. Yes, then the indication changes, and now sir, congenital anomaly is up to 24 weeks with the opinion of two doctors. Two doctors have to give an opinion. Is it clear to all of you? And before we proceed further, please don't forget to subscribe to the YouTube channel and also follow us on Insta. Chalo, one more important clinical case. Longish question. What is the diagnosis? Okay, what is the diagnosis? Yeah, beta, this is also the main movie. Picture abhi start, don't worry. Okay, yes, main movie you will see it on the day, on the FMG day, when you will come out and tell me, sir, everything was from your lectures. Yes. Okay. Yes. Now tell me this. Okay, so what is our diagnosis? Yes, sir, the diagnosis is, what is the diagnosis? The diagnosis is that, yes, why am I saying that, sir? There is obesity present, acne, hirsutism, infertility. So all this is suggestive of PCOS, and now the new name, PMOS. Okay, polycystic ovarian syndrome. And polyendocrine metabolic ovarian syndrome, that is fine. PCOS, PMOS, don't worry, that does not matter. Now here, before we proceed further, what criteria we use for diagnosis of PCOS? Yes, sir, we are going to make use of the Rotterdam criteria. Again, a very important MCQ. Rotterdam criteria, where there is an ovulation, hyperandrogenism, and the famous ultrasonography picture. Yes, can you tell me how will the follicle measure? What will be the follicle size? Yes, sir. All the follicles are chota. Okay, the follicles are all 2 to 9 millimeter in size. It is all immature follicle. Is this understood to all of you? So an ovulation, hyperandrogenism, and this is the famous necklace pattern. Necklace, you will remember BA picture bhi aane wala hai. 2 to 9 millimeter. Okay, and any 2 out of 3 should be present. To make the diagnosis. Is it clear? Now, please pay attention. I am going to give you a mantra. I'm telling you the answer in a minute. इसका आंसर बता रहे हैं, don't worry. अभी इसके पहले और एक आंसर, और एक MCQ. Now tell me this. Chalo. Again, we have got a patient who has obesity, facial acne, hirsutism, testosterone elevated. Look at the ratio also. FSH9, LH36. What's the ratio of FSH to LH over here? Sir, LH is increased. 9 is to 36. 1 is to 4. Abnormal ratio. Yes. Is it clear? So again, when longest question come, student panic. Long, and I'm going to tell you a mantra, lifelong you will not forget. How many want to do drilling? How many want to do drilling over here? Drilling किसको करना है? I will put you in jail. जेल में डालेंगे. Why जेल में? Anybody? Drilling क्यों करना है? Okay, please tell all your friends and colleagues also to join. Okay, that the session has started. Beautiful session is going on. Tell all your friends and colleagues also to join. Okay, yes. Okay, is it clear to all of you? Who wants to do drilling? Yes, sir. If in a 24-year-old girl, if in a young patient you do drilling, I'll tell you why. You are going to go to jail. It's hardly ever done. Okay, hardly ever done. Now, I will tell you the mantra. Lifelong, you will not forget both the MCQs. I'm going to tell you the perfect management. Okay. So now all of you, please pay attention. Please pay attention. Whenever we have got a patient of PCOS, or now the name is PMOS, you have to first see what the patient wants. Whether the patient is infertile, whether the patient has come to you with infertility, or patient says doctor, I am unmarried, or I'm not married, but or even if I'm married, I want treatment for acne and hirsutism, and along with that irregular periods. That is what I want the treatment for. Now, yes, infertility is because of what? Can you tell me one word? So here are you thinking? Infertility is because of what? Sir, infertility is because of an ovulation. So therefore, my dear student, we will go for ovulation induction. Ovulation induction. And all of you look on the board. When this question comes directly, many students mark clomiphene citrate and wrong. Clean bold. Clean bold. Please understand this. Why? Sir, clomiphene citrate was the first drug of choice. Was. Purana, 2018. So if you see my lecture of 2014-15, I should use clomiphene. Now, today, yes, sir, letrozole is now the first drug of choice. Please keep this in mind. Specifically for PCOS, letrozole is giving better results. And therefore, here the patient is married for 4 years. She is planning treatment for infertility. She will require ovulation induction, and we don't give her ocipils right now. There is no risk. Yes, and clomiphene has got no role, and HMG is a powerful injection. That is second line, third line. The first line choice is ovulation induction with letrozole. And what is this metformin for? Yes, sir, because the patient is having obesity, there is going to be insulin resistance, and therefore again a very important MCQ has been asked in the exam. Okay, sir, what is the initial management for PCOS? Yes, sir, lifestyle changes. Do not forget this, my dear student. Lifestyle changes, diet, exercise, weight loss, ये सब is very 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 extremely important. Is this understood to all of you? So do not make this mistake. This question has also been asked to you. Okay, sir, whenever we have a patient of PCOS, do not forget this. That is understood. Diet, weight loss, lifestyle changes. Okay, lifestyle changes. Examiner love this. Lifestyle modification. Is this crystal clear to all of you? And that is where the metformin plays a role. But sir, when I have a second kind of a patient, clap if you feel happy. नाम में ही आंसर है. Patient says, doctor, I don't want infertility treatment. I want acne hirsutism. Clap if you feel happy. PCOS. उल्टा कर दो OCP, ठोको ताली. Nobody will teach you like this, is my guarantee. PCO OCP means what? Okay, sir, all the problem of polycystic ovary. Just ulta. Sir, MCQ क्या है? MCQ is PCO. You will inverse it OCP. Clap OG in the chat box. And therefore, here, my dear student, when we have, yes, here married lady. But please read the question correctly. Sir, she wants the treatment for hirsutism. Look at the question. Sir, patient has come to you. Patient has come to you. Very good. Okay. Patient has come to you for treatment of hirsutism. Did you read this or not? Ye padha ke nahi padha? So when the patient wants treatment of hirsutism, I have to go for OC pills. PCO, ulta kar do OCP. Drilling is almost never done nowadays, and specifically never in unmarried girl. If in a young girl, clomiphene, letrozole will be required if you are clomiphene letrozole will be required if we are planning pregnancy, and drilling is almost kachra it's a last resort. We don't do it. Okay, so PCO OC pills are given, and that is the answer. Clear? So ye aapka ho gaya ye MCQ, and in this MCQ what is the answer? Yes sir, letrozole I will give, and letrozole ke sath metformin. So I finished the flow chart by telling you both the questions ho gaya aapka, and here metformin can be added with letrozole also. Letrozole plus metformin can also be given, and OC pills plus metformin can also be given. Is this understood to all of you? And do not forget about diet, lifestyle modification. Is this understood? And my dear students, it's your final chance. Just give 4 hours. I'm telling you, just give 4 hours. We had 3 sessions live now. The recordings are available. Easily you can see at 1.5x speed. Just in 4 hours, your score in OBGY. If you are still stuck up at 10, 14, 15, after just this 4-hour session, the score is going to boost up to 20, 25. 10 marks more you will get. All the important IBQs, all the clinical cases, and all expected MCQs. Download the OGGuru app just in 199. When you will walk out of the FMGE exam, you will message me and call me that, sir, super, all my questions were from this lecture. So just download, and you can easily finish off today, tomorrow only. 1 week before the exam, you can revise the entire OBGY just in this 4 hours. It's the fastest possible option. Chalo, one more very important MCQ. Girl is brought to the OPD by the mother that the menarche is not yet attained. Which of the following is a case of primary amenorrhea? What is the case of primary amenorrhea? Is this understood to all of you? Okay, so very important. Again, sure, this question is coming. The primary amenorrhea definition has changed. Definition has changed. Is this understood to all of you? Yes. The old, very quickly I will tell you that, sir, the old criteria was 14 years and 16 years. Is this clear to all of you? 14 and 16 was old. Why we have two? Sir, when secondary sexual characters, okay, secondary sexual characters, okay, please pay attention. So if I see a girl, thelarchy, pubarchy, there's no breast development because TPM, thelarchy, pubarchy, breast development. No, but the mic sound is all okay. Hello. Okay, now can you see and just check? Okay. Secondary sexual character. Yes. So, sir, if secondary sexual characters are absent, that means there's no breast development, all that, then at the age of 14. And if secondary sexual characters are present, then at the age of 16, I will wait and I will label it. That means if breast and axillary is present, I will wait till 16. But now this has changed. This 14 has become 13. This 16 has become 15 years. Is this crystal clear to all of you? So please understand this. 14-year-old, no menses with breast development, I can wait. Is it clear to all of you? 13-year-old, no menses with breast development, also I can wait. Is this crystal clear to all of you? Here we can wait till 15, and all of you correct. C is the answer. 13-year-old, no menses without breast development. C is the answer. 14-year-old is the old answer, old criteria. Yes, 14-year-old no menses without breast development is the old criteria. Okay. Okay, yes, don't worry. Okay, so this is very important to all of you. Is it crystal clear to all of you? So here in both option 1 and option 2 we can wait because they are 13 and 14, no menses. With breast development is there, with breast development, so we can wait till 15 years. Is this understood to all of you? Yes. Chalo, next, very very important. Now this question come na, student again make a mistake. What is the most common cause of primary amenorrhea? What is the second most, third most? Okay, so now all of you look on the board. The problem with mistake the student make is, okay, here they directly go for Turner's. What is ovarian dysgenesis? Sir, ovarian dysgenesis is Turner's syndrome. Okay, Turner's syndrome. Okay, but that is not the answer. Why that is not the answer? Yes, no beta. Turner's syndrome or ovarian dysgenesis is the number one most common cause. Question क्या पूछा है? Second most common cause. They can just to twist you, just to see in the exam panicky. Yes, sir, Mullerian agenesis or RMKH is the second most common cause of primary amenorrhea, and androgen insensitivity, another name is testicular feminization syndrome, is the third most common cause. Is it clear? So with one MCQ, three MCQs done. बात समझ में आ गया? One MCQ, no, hypothyroidism is not. Okay, is it clear to all of you? Is it clear to all of you? So see, one question, three. I repeat, Turner syndrome is the first most common cause. This is the most common. Okay, that is the most common cause. Okay, but the question is about the second most common cause. So please read the question correctly. I always tell the students you are supposed to read the questions correctly. Okay. Mullerian agenesis or RMKH is the second most common cause, which is the answer over here. Okay, now very very important short PYQ. This is a extremely important PYQ. 7 star, 5 star, surely going to come in the exam. Surely going to come. Chalo, tell me the answer. Okay, yes, what is this? Now please pay attention. What is the question? Okay, sir, there is primary amenorrhea and along with it absent uterus. So whenever you get this combo package, my dear student, I am going to give you a solid mantra and a solid tip. Primary amenorrhea, absent uterus, this combo package you will get every year. You will get this every year. बात समझ में आ रहा है? Yes, primary amenorrhea, absent uterus, when we have, what are the only two options in the whole world? In the whole world, only two options are, sir, either RMKH syndrome or androgen insensitivity syndrome. Is this understood to all of you? Why? Very important. Because, sir, Turner's syndrome, uterus is present. This is a very important mistake student make. Turner's syndrome, what is the karyotype also we'll discuss, but Turner's syndrome, uterus is present. Kalman also uterus is present. So when you have primary amenorrhea absent uterus, think of only these two. Crystal clear to all of you? Clap. ठोको ताली. तो ये दो को याद रखना है. Now, how will I differentiate both of them? Yes, sir. Here the gonad present is ovary. Here the gonad present is testes. And very, very important, of course, if I do the karyotype, this is 46XX and this is 46XY. ये तो लड़की नहीं, ये तो लड़का है. भाई मेरी गलती से बहुत बड़ा मिस्टेक हो गया. Is a boy. But that is if I do a blood test. What is the most important thing which you look over here? Breast. Sir, breast is not a difference. Sir, breast is well developed in both of them. Is it understood to do not look at the breast? Breast is there. What are we going to look at? Yes, sir. Axillary and pubic hair. We will be looking at axillary and pubic hair because axillary and pubic hair is androgen dependent. and in column number 1, axillary and pubic hair is perfectly present or well developed, but here axillary and pubic hair is absent, or to make the paper tough they can even give you sparse. Is this crystal clear to all of you? And therefore now if I look at it, crystal clear: primary amenorrhea, absent uterus, absence of axillary and pubic hair. The answer is androgen insensitivity. Is this understood to all of you? And what is this lump in the inguinal region? Yes, sir. These testes are going to be undescended testes, because descent of test is androgen dip. Is it also crystal clear to all of you? So please keep this in mind. What is this lump felt in the inguinal region? Undescended testes. Sir, undescended testes are felt. That will also be there. बेटा पार्शियल में क्या होगा? रिमेंबर प्रणिधि, पार्शियल विल बी एम्बिगुअस जेनेटेलिया. ओके, कंप्लीट में द जेनेटेलिया विल लुक लाइक अ फीमेल, एक्सटर्नल जेनेटेलिया. सो यू लेबल द गर्ल एज अ गर्ल चाइल्ड. पार्शियल विल हैव बाइफिड पेनिस, एम्बिगुअस जेनेटेलिया also will be there. Such will part will be there, part will not be there. Okay, is it clear to all of you? So partial androgen syndrome, you will see you can see a bifid penis, some features of virilization or boy like features will be there. So the genitalia may also be look like, it might not be very clear. Okay, so but it will not look like a complete female. Okay, you can get a bifid penis and you can get some like this. Okay, bifid scrotum and all that. Is it clear to all of you? Yes. So complete androgen insensitivity, the genitalia look like a female and therefore they present to the gynac OPD, but they are actually XY. Okay, very very important. Chalo, now tell me this again, match the column, new style MCQ. Okay, so now before we proceed further, if I give you, now tell me the answer, all of you. If I give you the answer, if I give you the MCQ, primary amenorrhea, absent, one more bonus MCQ. If I tell you primary amenorrhea, absent uterus, and if I tell you well developed axillary and pubic hair, now what is your diagnosis? Chalo, same 4 options. Here, these 4 options are there. These 4 options are, what's your answer? Yes, breast is well developed, will be told to you. Fine. Breast plus well developed axillary pubic hair, that is RMKH. Yes, RMKH syndrome. So see, one word in the question also change, option change. OG in the chat box. Is it crystal clear to all of you? Is it clear to all of you? तो यहाँ पे sir, primary amenorrhea, absent uterus, breast well developed, but well developed axillary pubic hair goes in favor of RMKH syndrome. All of you superb. Movie House, Mannu Gujjar, Life of a Doctor. I cannot take all names, but all of you super. Is it crystal clear to all of you? And this, my dear student, when you get a match the column, student panic. Turner's syndrome, all of us know, is 45XO. So 1A, 1A. Though option rule out. RMKH, I just now told you, is a perfectly normal female. 2C. And you have the answer 2C. Androgen insensitivity is XY, I told you. Okay, so 3B, and Glanfenter is 47XXY. What do you think is the answer? Yes, sir. Option. So, एक MCQ के साथ 4. Clap if you feel happy. Okay, 4 MCQs done in 10 seconds. All these have been asked in the exam. Okay, yes, MRKH will be XX. So 2C, 3B, 4D. Is it clear to all of you? That is the answer, option B. Yes, all of you correct. Okay. Yes, now again a short topic going to come 100% in the exam. Okay, which of the following are screening tests used in the second trimester for aneuploidy? Specifically, when they mean aneuploidy, basically it is telling you trisomy 21 screening. Chalo, tell me the answer. Anybody? So now next 3 minutes, lots of MCQ you will get in the exam. So please pay careful attention for the next 5 minutes. First of all, can you tell me what is the triple marker test and what is the quadruple marker test? Before that, student problem kahan se start hota hai? Sir, how is this test done? Anybody? How is the triple marker and quadruple marker test done? What is the sample? Anybody? How to do this test? How to do the triple marker, dual marker, quadruple marker test? Anybody? Yes, the most important part is okay, the triple marker, double marker, quadruple marker, all the tests are done on maternal serum. Is it understood? The first answer I get all over India when I travel, that student tell me, no, wrong, beta, cordo, wrong, clean bowl, dandi, gul. Okay, I get answer, amnio, CVS, cordo, all kachra dustbin. Abhi life mein bhulenge nahi kabhi. It is a simple test done on mother's blood, maternal serum. Clap if you have learned something new on a Friday evening. Thoko tali. So it's a test done on maternal serum. Sir, I have got the test, triple marker test and quadruple marker test. What it is, I will tell you. They are done in the second trimester, T2. T2 is my short form. They are done between 16 to 18 weeks of gestation. Perfectly correct, sir. We have got HCG, alpha fetoprotein, and unconjugated estriol. Unconjugated estriol, E3. Is it clear to all of you? It is not estradiol, it is E3. Again, how do I remember? Sir, यहाँ पे 3 है because यहाँ पे 3 markers है. Again, you tell me what is high, what is low. Yes, sir, HCG higher than normal, other two lower than normal. Is this understood to all of you? And if I add, so this is first, second, third, and if I add the fourth marker, inhibin, inhibin A is the fourth marker, that becomes a quadruple marker test. Again, also it is higher than normal. Is this understood to all of you? But both of them are done in the second trimester, 16 to 18 weeks. Is this crystal clear to all of you? Is it clear to all of you? Yes. And what is the test which I do in the first trimester for screening? It is called as a dual marker, where I do HCG and PAP-A, pregnancy associated plasma protein A. And again, remember, sir, HCG is high here also, but PAP-A is lower than normal. So when that's, but this is only a screening test. It's not a confirmatory test. All these are screening tests. So now you know the answer. Okay, screening test in the second trimester, alpha fetoprotein, inhibin, HCG. Very good. Sir, HCG is also done in the first, but HCG is done in the second also. Okay, so HCG is done in both. HCG you can see is a part of all. So HCG is done in both the trimester, both this, but PAP-A is only done in the first trimester. Is it crystal clear to all of you? Clap. This is short coming in the exam, and remember, all these are screening tests. Can you tell me before I proceed further, what is the only test in the whole world which is a confirmatory test? Confirmatory test कौन सा है? The confirmatory test is karyotyping. Karyotyping is 100% confirm, black or white. Karyotyping, again, how do you do it? Okay, how do you do it? Okay, karyotyping, how do we do it? Sir, I can do by doing a chorionic villus sampling or doing a amniocentesis. Again, important MCQ. Again, when do you do it? Again, MCQ. So ek ke baad ek question. Chorionic villus sampling is done in the first trimester. Amniocentesis is done in the second trimester. Keep this point in mind. Very important MCQ. Okay, is it crystal clear? So all of the following are screening tests used in the second trimester except PAP-A. Sir, PAP-A is done only in the first trimester. Is this understood to all of you? Chalo, now one more. Now one more you will come to know, which is not true, which is not true for trisomy 21. I told you, sir, PAP-A is lesser than normal. Yes, sir. Alpha fetoprotein will also go lesser than normal. It's a part of your triple. And NT. What is this NT scan? Yes, sir, it's a sonography, but it's also a method for screening. And that is also NT will increase. What is the answer? Sir, HCG will not decrease. HCG will increase. Yes, HCG will not decrease. HCG will increase if in case the baby has high. Yes, HCG high. Okay, HCG high. Okay, so this is the answer. PAP-A will decrease is correct. Chalo, now tell me what is this NT scan? What is the NT scan? Yes, sir. It is also a method for finding out. NT scan is done when? NT scan is done between 11 to 13 weeks of gestation. One more important MCQ. Yes, nuchal translucency up to 3.5 millimeter is considered normal. Anything more than 3.5. If NT is more than 3.5 millimeter, then you have to suspect. It is a suspicion. It's a doubt. Do confirm it. It is a doubt. Likely it could be a Down syndrome baby. Is this understood to all of you? Yes. Again, a new style pattern. Students panic when the question comes. Please understand this. What the student think? They directly start marking from here. 1, 2, 3, 4. No. Please understand this. This whole is a part of your bloody question only. ये पूरा question ही है. ऑप्शन यहां से शुरू होता है, मार्किंग यहां से करना है. इज इट क्लियर टू ऑल ऑफ यू? सो इट्स अ वेरी बिग क्वेश्चन. You have to read and then select the correct answer from the code given below. So this is a new pattern paper MCQ. Don't get panic. You will get it all when you listen to my lectures. Is it clear? So what is the question? The question is, I want a indication as well as what are the prerequisites for ventus. Ventus, another name is vacuum delivery. So instrumental delivery का बात हो रहा है. Anybody? क्या है ये? Yes. So please understand this. Please understand this. Okay, what are the indications for instrumental delivery? Yes, sir. Now remember this. Okay, sir. Whenever we have, first I'm talking of both forceps or vacuum. Which I apply forceps or vacuum. Please understand this. If there is fetal distress, if there is fetal distress at full dilatation, then I can apply when the patient is fully dilated and I need to apply. If there is maternal exhaustion, matlab maternal distress लिख लो. Mother says, doctor, I'm pushing, I cannot push. And third is prolonged second stage, or if I want to cut short second stage, if I want to cut short second stage in heart disease and all that. Is it clear to all of you? Now, one more very important point. When I apply forceps or vacuum, please keep this in mind. The pelvis should be adequate. Pelvis should be adequate. Ye rule you have to keep in mind. There should be no cephalopelvic disproportion. Is this crystal clear to all of you? Clap. Now, V for vacuum, V for vertex. Vacuum I cannot apply on the baby's face. क्या होगा? If it's a face, I apply vacuum, eyeballs will pop out. आँख बाहर आ जाएगा. So vacuum is only for the baby vertex. And all of you look on the board. Yes, so forceps can be applied on after coming head of the breech and all that, but vacuum is only for vertex. So delay in the second stage of labor, yes, I told you I can apply. Non-reassuring fetal heart rate, that means that is fetal distress, also I can apply. And of course vertex presentation is very important. It has to be a vertex. What is the answer? Yes sir, 3 नहीं होना चाहिए. Why? Because a gestational age less than 34 weeks, it is a absolute contraindication for vacuum V. Vacuum Y. Because sir, why this is prematurity. If the baby is premature, in a prematurity, if I apply vacuum, there is increased risk of intraventricular hemorrhage. Is this understood to all of you? And therefore 3 should not be there. 3, wherever 3 is there, it is out. Very good. 1, 2, 4, fire. Is it clear? 1, 2, 4. Option B is the answer. Because I repeat, whenever it's a prematurity, 4 steps is okay. Vacuum prematurity is the absolute contraindication for vacuum because it will increase the risk of intraventricular hemorrhage. Okay. Pelvis should be adequate. Baki sab hai. Crystal clear to all of you. Can I get 10 thumbs up? Yes. Already told to you. Chalo. Already told to you. What is the answer over here? Yes, please understand this. NT scan 8 to 10 weeks is early. We do it between 11 to 13 weeks of gestation. And one more MCQ. Can you tell me के 18 to 20 weeks पे कौन सा scan करते हैं? Anybody? Which scan is done at 18 to 20 weeks? This also is asked to you. Most important, if they tell you single most important scan, okay? WHO says that if in the whole pregnancy lady has to do one scan, it has to be this scan. Single most important scan of the whole pregnancy, 18 to 20. The session started at 6:45. Okay, don't worry, you can see the recordings will be available. Okay, it is called as a anomaly scan or malformation scan. Okay, no, but a scan का बात हो रहा है. Okay, so amniocordo wrong. Anomaly scan or the malformation scan is the single most important scan. Yes, level 2 scan, what we call it, or we call it as TIFA scan. Is it clear to all of you? Yes, anomaly scan मतलब और targeted imaging for fetal anomaly. TIFA scan जो बोलते हैं. Forget the word TIFA. Targeted imaging for fetal anomaly, but it is called as the anomaly scan or malformation scan to check for all the anomalies in the baby. 18 to 20. Single most important scan. Very important. Clap. Thoko tali. Is it clear to all of you? NT scan का answer is 11 to 13 weeks. Okay, 13.5 तक जा सकते. Okay, yes. चलो. Now again a very important. ये क्या है पिक्चर? मेनी स्टूडेंट देख के कॉपर टी. इज इट अ कॉपर टी? अगेन IBQ. So starting में बहुत सारे. Those who have joined in late, after the session is over, please see it from the beginning. Okay. This is not a copper tea. This is sir. This is sir. No problem, beta. Prabhujaran Abhishek, welcome. Okay. This is a Myrina or a brand name Myrina. This is LNG intrauterine device. This is LNG intrauterine device. It does not contain progestin and estradiol. It contains LNG. But what is the total quantity? Yes, sir. Totally, it contains 52 milligram of LNG. And do not forget, why do I also call it LNG 20? Because 20 microgram per day. Is this understood to all of you? So do not get confused. 52 milligram is the total, which is the answer over here. Totally 52 milligram and 20 microgram is released per day. Crystal clear to all of you? And one very important, can you tell me what are the uses other than, again MCQ आने वाला है, short question, other than birth control, where is this used? Yes, sir. What happens is that the menses keep on becoming scanty, and menses can even stop. So because of continuous progesterone, because we are giving continuous progesterone, it does not allow the lining to grow only. So endometrium will not grow. Okay, like if the beard is growing, then I will shave. If the beard is not growing only, Tiger Shroff, what will he shave? Tiger Shroff बोलेगा sir मुझे क्यों तोड़ा? Okay, but yes. So sir, if the beard is not growing only, there's no need to shave. Is it clear to all of you? So same thing, sir. Okay, sir, when the lining is not growing only, the menses will become indirectly become only spotting or scanty, or patient can even go into amenorrhea, progesterone induced amenorrhea. Very good. And therefore I can use it in management of heavy menstrual bleeding or menorrhagia, or very good dysfunctional uterine bleeding. Very good, all of you. Don't forget this very important concept, progesterone induced amenorrhea. Is it clear to all of you? Chalo. Again, a very important PYQ. Whenever I have a patient who comes to you with septum, I'll make you a perfect lifelong. You will not forget hysteroscopy, laparoscopy. क्या है ये? Midline septum in the uterus. Septum in the uterus. Anybody septum in the uterus. तो क्या करना है? Is it clear to all of you? Yes. So septum, sir, my dear student, will I do hysteroscopy or will I do laparoscopy? Lifelong, you will not forget. All of you look on the board. Sir, septum, remember, is projecting into the cavity. Okay, sir, septum is like this. Sir, septum projects to you in the cavity of the uterus. Septum is like this. Is it crystal clear to all of you? So if I do laparoscopy, what is laparoscopy? Sir, laparoscopy is to see from above. There is no roll. When I put in a telescope from above, I will only see the outer surface. Laparoscopy picture I've already shown you today only. I showed you laparoscopy chromoperturbation. Those who have joined in now can go back and see the lecture afterwards. So here, sir, we put in a telescope through the cervix and we look at the hysteroscopy. And what I can do, sir, I can cut the septum like this, like this, like this, like this, cut it, which is called as a hysteros. See, I'm cutting, I'm showing you. Aisa, we go and we cut like this and make the cavity normal. So this is a hysteroscopy, septoplasty or septum resection. Is this understood to all of you? Laparoscopy has got no role. I don't do laparoscopy and laparotomy. We won't do because septum, sir, projects into the cavity and therefore always remember I have to do hysteroscopy. Now one more very similar. Clap if you feel happy. Chalo, this is absolutely going to come. You will remember me. This question is going to come short. 7 star. Hysteroscopy is for all except. Okay, hysteroscopy is for all except. Is it crystal clear to all of you? Yes. Now, chalo, tell me. So now, please pay attention. Anybody, what is Asherman syndrome? Today, again, I shown you the HSG. Go back and check. Okay. So all of you look on the board. Hysteroscopy, my dear student, remember, is anything to do with the cavity of the uterus. Is it clear to all of you? Cavity. That means, what am I saying? All of you look on the board. So if this is the uterus, and inside the uterus, if there is intrauterine adhesions or Asherman syndrome. What is Asherman syndrome? Sir, intrauterine adhesions, we know that. Okay, yes. Similarly, sir, endometrial polyp. Yes, sir, endometrial polyp, or if it is a submucosal fibroid. Okay, or I just now told you even septum, even if it's a septum, then all these are going to problem with the inside the uterus, and all this I need to put in a hysteroscopy. Is this understood to all of you? And hysteroscopic guided, I can cut the septum also. See like this. Can you see the surgery being done? Cut. Very tricky surgery. You have to be very careful. Okay. So I can cut the septum. Is it understood? And cut the Asherman. Okay. So indicated in all of the following except Asherman syndrome, hysteroscopy, endometrial polyp. Of course, all this is will cause infertility. So very important. All this will lead to infertility also. Adhesions, polyp, septum can cause infertility. So for infertility also, we have to do this. Endometriosis requires laparoscopy. Endometriosis features, chalo tell me. My student, endometriosis में you see fruit salad. Endometriosis you see fruit salad मतलब what? Sir, endometriosis में everything is outside the uterus, isn't it? There is no role of hysteroscopy. Why? Because, sir, in endometriosis, everything is outside. I will put in a telescope through the anterior abdominal wall and I will see what? I will see in the ovary chocolate cyst. chocolate cyst in the ovary you will see. So there could be adhesions between the tube and the ovary. Yes, and very good. Somebody told me, sir, the okay, there will be black spots, matchstick burnt spots. Okay, matchstick burnt spots. And also do not forget the word fruit salad. What is this fruit salad? Sir, blueberry, red raspberry. So all that, remember, endometriosis, I'm writing endometriosis requires laparoscopy. Is this crystal clear to all of you? Yes, adhesions and powder bone. Okay, so endometrium requires laparoscopy. Do not, and biopsy is the gold standard. Okay, crystal clear to all of you. चलो, very simple. Do not make a mistake in this. Surely ये question आने वाले हैं. ये question surely आएगा. We have grayish white discharge, positive whiff test. What is this positive whiff test? So okay, remember that means I'm seeing the outer view, terrace view. कैसे याद रखना है? Sir, whenever we are doing a laparoscopy, remember this, we are going on the terrace of the building, and from the terrace of the building we are seeing the outer side. So terrace view, outer view. Okay, outer view is laparoscopy. Okay, and hysteroscopy, remember, is the cavity. It is from inside the classroom view. If all of us are inside the classroom, I can tell you how many students are there. All right, crystal clear to all of you? Yes, chalo, ye kya hai? Yes, sir, positive whiff test. And this is what? What is this positive whiff test? Sir, whenever you take the secretions to that I at 10% KOH, we will get a fishy odor. Fishy odor because of release of amines. Fishy odor because of release of amines, and that is metronidazole. Metronidazole. Okay. Whiff test. And one more important things will come out. I'm still writer all that also. I will tell you, don't worry about it. Okay. Metronidazole. Okay. Partner treatment not required. Okay. This is because of imbalance. This is thought to be because of imbalance. ये भी important MCQ. Imbalance between the good and the bad bacteria. Is it crystal clear to all of you? Yes. चलो, extremely important MCQ. Short. Somebody was asking me, yes, sir, please tell me Sheehan syndrome. I'll teach you Sheehan syndrome. चलो, tell me this. Quickly. चलो. What is this? Now, I have got a patient who had some incomplete abortion, underwent a curettage 4 months that she has not yet got her periods, amenorrhea hai. And what is the clue? FSH5. I'll give you 3 variations. This MCQ, I will give you 3 variations in the next 5 minutes. What is it? Tell me now. FSH5 is normal, high or less? Yes, sir. FSH5 is normal. FSH5 is normal. Okay. Now, all of you look on the board. FSH5. No, those are saying, okay, FSH5 is normal. I also tell you the values. Dhyan se sunna. Okay, so please understand this. Lifelong you will not forget. Sir, pituitary is the master. Pituitary is the master and ovary is the servant. My students love this analogy which I give. Pituitary is the master, ovary is the servant. समझ में आ रहा है? So now you only tell me. All of you only tell me, sir, suppose if the ovary is not functioning properly, if the ovary is not functioning properly or ovarian function has gone down, what will the master do? Master क्या करेगा? Master will shout more loudly कि बाबा काम करो, काम करो, काम करो. Isn't it? Like if you're not studying, what will all your professors say? Study, study, study. Is it clear? So as the ovarian function goes down, FSH keeps on going high, high, high. And therefore, my dear student, remember this, कि whenever it is ovarian failure, if it is before 40, if it is less than 40 years old, we call it as premature ovarian failure. Or if another thing, what is natural ovarian failure? Anybody? Whenever the lady reaches menopause. Yes or no? Whenever the lady reaches menopause, menopause is also natural ovarian failure. In that cases, the FSH is going to be very, very high. Yes, sir. I will tell you the results also. So if you get FSH 20, 30, 40, after menopause, the FSH becomes 40. Is this understood to all of you? So remember this, when the FSH is generally more than 40, it indicates menopause. So if you get high FSH, okay, FSH is going to be very, very high, 20, 30. I'll tell you the values also in some time. Is it clear? Now, pituitary failure. Master himself is sleeping. like your Sheehan syndrome, postpartum pituitary necrosis. Okay, postpartum pituitary necrosis. Okay, that is your Sheehan. Somebody asked me. So what will happen in pituitary failure? Sir, FSH will be very, very low, isn't it? Okay, sir, if the pituitary itself has failed, pituitary का ही problem है, तो FSH will be very, very low. Isn't it, all of you? Yes, sir. And what is intrauterine synike or Asherman syndrome? Sir, when Asherman syndrome is there, pituitary is also normal and ovary is also normal. It is a fault with the uterus. It's a problem with the uterus. So pituitary also normal, ovarian function also normal, and therefore FSH will also be normal. Clap, clap if you have learned something new. Is it clear? So all of you, sir, this FSH5 is normal and that is suggestive of intrauterine. I repeat, in premature ovarian failure, FSH will be very, very high, and in pituitary failure, FSH will be very, very low. Now coming to your values which you wanted to know. Okay, so remember this, that for anybody normal value kya hai? Normal. Okay, so remember when they want to give you normal, okay, remember this, that 5 to 10, okay, 3 to 10 or 5 to 10 is considered normal. Okay, now so they will not give you borderline 11 12. Is it clear? When they want to show you FSH is low, they will tell you 0.1, ऐसा MCQ आया था, 0.1, 0.2, 0.3, they will give you this value. Less than 1 they will give you. Is it clear to all of you? When they tell you FSH is less than 1, okay, less than 1, very, very low, that is what's your answer? Pituitary failure. Pituitary failure mein FSH will be there. Okay, and when they want to show you high FSH, please understand this, again they will not give you borderline, they will give you directly 20, 30, 40. Is this understood to all of you? So FSH, yeah, less than 10 is normal. Okay, so around 10. Okay, so some books say 3 to 10, some say 5, but they will give you 5, 6, 7. So they tell you 5, 6, 7, go as it normal. Is it clear to all of you? When they want to tell you FSH is high, they will only give you not 11, 12. They will tell you 20, 30, 40. More than 40 is menopause. Okay, that's again a MCQ. FSH more than 40 is suggestive of menopause. Matlab in menopause, the FSH is more than 40. Yes, ovarian failure. Okay, crystal clear to all of you. So here now you only tell me, chalo, variation in the question. If here I tell you this FSH5, I make it FSH50, what is the answer? If I make it FSH50, what's the answer? Okay, yes, if the FSH is 50, then it is, sir, ovarian failure. Is it crystal clear to all of you? Yes. If I make it FSH 0.5, if I make it 0.5, then it will become pituitary failure. Clap. Ek variation, ek. Sir, here I go back to the normal question, FSH normal. So intrauterine synike, FSH normal. Superb. Chalo. Now tell me this. Whenever I have got a young patient, nulli gravida, young patient with a prolapse, who wants to do hysterectomy, I will put him in jail. Why jail? Sir, अगर 27-year-old patient का uterus निकाल दिया, jail. Lee Force also have to go to jail. That's only for postmenopausal. And my dear student, Fothergill surgery is to be avoided. Almost never done. Can you tell me why will I avoid Fothergill surgery? Why I will do Fothergill surgery? Avoid, because can you tell me this? Yes, sir. I'll tell you that Fothergill repair causes all of the following complication except. Sir, what is Fothergill operation? Sir, in Fothergill operation, we do cervical amputation. Sir, we chop off the cervix, and in Fothergill operation, cervical amputation is done, which will lead to cervical dystocia, or cervix can become weak, preterm labor, and most importantly, cervical incompetence. And cervical incompetence always causes abortion in the second trimester, and therefore this is the first trimester. Abortion causes are chromosomal genetic, वो सब बात समझ में आ गया. So never do this. And therefore all of you, Akshay Kumar Katrina Kaif movie, how many of you know Akshay Kumar Katrina Kaif movie had come 10 साल पहले? Sing is king. Repeat after me in the exam, you will remember me. Sing is king. Yes sir, Sing is king movie had come, and Sing is king, but Sling is also king. स्लिंग इज किंग का मतलब है स्लिंग इज द बेस्ट ऑपरेशन, स्लिंग सर्जरी is the best. Is it clear to all of you? And which is the answer? I will do sling. Sling is king. Sling surgery, another name cervicopexy. Clap. Nobody will teach you like this is my guarantee. Akshay Kumar in the house, Katrina Kaif in the house. Sling is king. Sling is king, and sling is also king. Sling is king matlab sling is the best operation, so which is always to be done in a young patient. Thoko tali, clap. Okay. And Fothergill operation will all cause except first, it always cause. And what is the typical specialty? Painless abortion in the second trimester. Okay. And my dear student, picture abhi baki hai. There are many more questions, but just 1 second. Please understand this is your life changing thing. Just give 4 hours. Download the OGGuru app, and just in 199 rupees you're going to get 6-hour session, which you will see at 1.5x speed easily, and in 4 hours time all the images, all the clinical cases, and all the expected MCQs will be done, and you will become expert in OBGYN, and your score is tremendously going to get boosted up. It's a single most important subject. Yes, cervicopexy or histopexy. Okay, so download the OGGuru app and quickly start seeing it after the session is over. Just today, tomorrow you'll finish off. But tomorrow your OBGY will be done. So quickly download the OGGuru app, get in touch with me on phone and WhatsApp on this number, and prepare for this. Again, a very important PYQ. What is this? History is also very easy, but what am I seeing? They will tell you ultrasonography of the uterus and the cervix pe focus karoge. This my dear student is the whole cervix. And what am I seeing in the cervix? All of you, what is this? Yes sir, why? What is this? Why? All this black is the fluid. So this is the pregnancy of the uterus. This is the sonography of the uterus, and if you just rotate the image, you will see a Y shape, isn't it? Aren't we seeing Y? Yes. Gravida 3, abortion 2. Patient has had 2 abortions in the second trimester. And again, to make it more history, they will give you painless abortion. This is cervical incompetence. Placenta is not near. Okay, cervical incompetence. Now what is this Y shape? Yes, sure. Okay, so just if you rotate the image, okay, can you see a Y like this? Yes, you can. All of you can see a Y, isn't it? Can you again look? I'm drawing it again. All of you can see the Y shape. Yes or no? See this, and this. Okay, now what is this? Very important, please pay attention. Okay sir, whenever the patient is there, the normal cervix, what is the normal cervix looks like? So normal cervix looks like letter T. Okay, this. So sir, the normally the cervix, anterior lip, posterior lip, if I just draw it in another color, so this is T. Is this understood to all of you? So T-shaped is normal cervix or a competent cervix. And what does this Y indicate? What does this Y indicate? Funneling, cervical incompetence. And what's the management? Also we know cervical and cervical. So all of you look on the board, because if the cervix is like this, uterus, if it starts opening up from above, so ye upper part opens up, and then the letter looks Y. So this is looking like funneling. Okay, clear cut. Is this understood to all of you? So T-shaped is normal or a competent cervix, and Y is funneling, suggestive of cervical incompetence. Short question is coming in the exam. Chalo, again a very important MCQ. Okay, again a very important MCQ. 28-year-old lady, 31 weeks, has suddenly headache, blurring of vision, oliguria, albumin plus 4, no convulsions, very important, no convulsion present. What is the best management? Chalo, tell me this. Okay, what is the best management? This Yes, anybody क्या है ये? Yes. So anybody tell me the diagnosis? Yes, it is not eclampsia. If somebody tells me eclampsia, it is wrong. What is the diagnosis? Sir, the diagnosis is impending eclampsia. Now, why impending eclampsia? Can you tell me why impending eclampsia? Now, ध्यान से सुनेंगे. जब ओजी गुरु है ना, जब मैं हूं ना, तो ओ बी इजी है ना. क्लैप. ओ बी इजी है ना का मतलब क्या है? सर, these are the 5 dangerous symptoms. O is oliguria, B is blurring of vision, E epigastric pain, H is headache, and N is nausea and vomiting. Okay, जब OG गुरु है तो O भी easy है ना. ठोको ताली. And therefore, sir, you can see in the question paper, this patient has got headache. This patient has got headache, blurring of vision, oliguria, BP is also very high, and therefore she becomes the patient of impending eclampsia. Who wants to wait and watch? You will have to go to jail, because if you wait and watch, mother will die, baby will die. तो जो wait and watch करेंगे जेल में डालो. Okay. Impending eclampsia, what do you do? Anybody? Yes, sir. Whenever it is impending eclampsia, please understand this. That is the last day of the pregnancy. Okay, please understand this. Okay, what you see in Hindi picture, कि हम माँ और बच्चे में से किसी एक को बचा सकते हैं, तो किसको बचाना है? Anybody? माँ को बचाना है कि बच्चे को बचाना है? Yes, sir, please understand this. When it is impending eclampsia, that is the last day of the pregnancy. Pregnancy cannot continue further. I have to do the delivery. And why delivery? Because delivery is the definitive treatment. ठोको ताली. So, sir, mother, because अगर mother है, पीछे पूरा cricket team आ सकता है. ओके, क्लियर. सो सर, माँ को बचाना है, डॉक्टर को भी बचाना है. सेव द डॉक्टर. गवर्नमेंट बोल रहा है सेव द टाइगर, चीता, बट ए डॉक्टर, यस, बट इम्पेंड. सो लेट द क्वेश्चन बी, ऑल ऑफ यू लुक ऑन द बोर्ड. लेट इट बी 20 वीक्स, 30 वीक्स, 32 वीक्स और 34 वीक्स. वॉट एवर मे बी द रिस्क, वॉट एवर मे बी द वीक्स ऑफ जेस्टेशन, नेवर वेट एंड वॉच. You will do the delivery irrespective. But before I do the delivery, I will give magnesium sulfate prophylactically to prevent convulsion, and then I will do the delivery. Is this concept understood to all of you? Please write down. Delivery has to be done irrespective of weeks of gestation. Clap. So all of you look on the board. Let this be 31 weeks. Let it be 28 weeks, let it be 26 weeks, let it be 36 weeks. Answer will not change. Of course, labetalol to control the blood pressure, but then deliver at 34 weeks, wrong. We are 31 weeks, wrong. And similarly, Maxulf, labetalol deliver at 37 weeks, again wrong. What is it? Sir, Maxulf to prevent convulsion, labetalol to control the blood pressure, and immediately induction of labor or delivery has to be done. Is this understood to all of you? So D is the answer. Is this crystal clear to all of you? D is the answer. Okay, never wait and watch. Again, after giving Maxulf, please don't wait. Okay, after giving Maxulf, we never wait and watch. Okay, so wait and watch never nahi karna hai. Maxulf is given to prevent convulsion. Of course, labetalol will also be given to control the blood pressure, and then immediately we have to do the delivery. Is it clear to all of you? Yes. And what is this? What all three things we monitor when the patient is on magnesium sulfate? When the patient is on magnesium sulfate, we monitor the knee jerks, respiratory rate, and urine output, and magnesium sulfate level 4 to 7 milli equivalents per liter. 4 to 7. Is it crystal clear? If it is high problem, and calcium gluconate is the drug of choice. Calcium gluconate. Okay. Urine output should at least be 25 to 30 cc per hour. Keep that also in mind. Is it crystal clear to all of you? Yes. Okay. So before we proceed further, please take 10 seconds and please download the OGGuru app and please subscribe to the YouTube channel. Lots of important videos and content are there and you can see, and also follow us on Instagram. Chalo, simplest question ye surely aane wala hai. Please download the app and also please subscribe to the YouTube channel. Okay, you are not subscribed, and share this video with all your friends and colleagues. What is it? Yes, sir. Primary amenorrhea, cyclical abdominal pain. This is cryptomenorrhea. Cryptomenorrhea, nothing much to discuss. And we can see tense, bulging hymen, which is, yes, tense, bulging hymen. And we are supposed to make a cruciate incision. This is a imperforate hymen. Again, a very important PYQ. Imperforate hymen, you will see a tense, bulging hymen. Bluish. Okay, tense, bulging hymen, bluish in color. Cryptomenorrhea, please keep this in mind. Cyclical amenorrhea, cyclical abdominal pain whenever we get. Don't make a mistake. Short MCQ is coming. Chalo, now again a very important MCQ. Again a very important MCQ. Whenever I have got a patient who is 32 years old, gravida to paravalvular, 35 weeks. 35 weeks with bleeding. So what it is, my dear student? Sir, whenever we have bleeding in the third trimester, whenever I have bleeding in the third trimester, what are the two things we have to keep in mind? Sir, I have to either think of placenta previa. PP matlab, or it is abruption. Of course, sonography, if I do, I will come to know, but that is not given in the question paper. Based on the history, yes, sir, placenta previa is always a painless bleeding. Abruption is always painful. Uterus is relaxed in a patient of placenta. Abruption is all blood inside the uterus, so uterine tone is increased, and you can get tonically contracted uterus. Blindly mark abruption. Okay, is it clear to all of you? So these are the two main things. Of course, placenta prevents the head from going down, so head is floating also. That also you keep in mind. Okay, and remember, high blood pressure. Preeclampsia is associated. Preeclampsia very likely to be present. Preeclampsia can lead to abruption. Here, preeclampsia, there is no association with preeclampsia. Is it clear to all of you? So now I know. Yes, very good, sir. Profuse, painless bleeding, BP normal, and uterus relaxed, and also head is floating. Can you see so many clues are there given in the question paper? Okay, yes, okay, and therefore this is not abruption, this is not eclampsia, this is placenta previa. Clap, thoko tali. Now one more management ka question. Chalo, now tell me this again. First, only the diagnosis. Anybody? Yes, this is again a patient of placenta previa. Now, can anybody tell me what is it? One word change. I'll tell you how the one word change answer change. This is again placenta previa. Why placenta previa? Sir, painless bleeding. BP initially, yes, of course, when there's lot of bleeding, BP will go down. Is it clear? So, बाद में BP can drop. But initially, if the BP is okay, because if they tell you BP is high, think of abruption. Okay, and uterus relaxed, head floating. So, this is placenta previa, no doubt about it. And what will I do? Okay, now, first of all, whoever in placenta previa says induction of labor, jail में डालो. और forceps delivery, jail में डालो. Why jail? Never, because please pay attention. In placenta previa, this is the uterus, This is the placenta. The placenta is in front of the presenting part. There is a baby inside. If you make the uterus contract, there is going to be torrential bleeding. Okay, is it clear? Torrential bleeding. No, uterus does not move up later, beta. Okay, uterus does not move up. Placenta can move up later. But that has to go before 30 weeks. Okay, please pay attention. If the placenta has to move up, if placenta previa is 20 weeks, wait and watch, placenta will go up. Why wait and watch? Okay, so never induce labor. Similarly, never apply forceps. Okay, thank you, Dr. Vikas. Thank you. Better just the trailer. Never, you cannot apply forceps in a placenta previa. Never. Okay, so never induce labor. You will cause more bleeding. You will have to go to jail. Okay, so LSCS only. But when? Okay, now remember this placenta previa. I can wait and watch. And what is the only purpose of waiting? The purpose of waiting is not for the placenta to go up. The purpose of waiting is for the fetal lung maturity. Fetal lung maturity. And what do we do when I wait and watch? Sir, I admit the patient, give her steroids and bed rest. This, my dear student, is called as MJ regimen. McAfee, Michael Jackson nahi, McAfee and Johnson regimen. And all the three conditions have to be satisfied. All of you look on the board. Sir, mother should be stable, isn't it? If the mother is not stable, then wait and watch for what? For the mother to die. Then don't wait. So look at the question paper. Sir, hemoglobin 11, BP 120, 70. So sir, mother is stable. Mother is stable. Yes, there should be obviously no fetal distress, isn't it? No fetal distress. Obviously, if there is fetal distress, wait and watch for what? For the baby to die. Then don't wait. Look over here, sir. Fetal heart rate 150 normal. Sir, fetal, there is no fetal distress. And the most important, my dear student, 33 weeks. And therefore, wait and watch is the answer. Thoko tali. Yes, wait and watch. Why? Because I would want to wait. Is this clear to all of you? I will wait and watch, which is the answer. Okay, but, okay. So if the pregnancy is less than 37 weeks, is this crystal clear? But all three should be there. Okay, so please understand, if there's fetal distress, then don't wait, directly do cesarean section. Mother in shock also, don't wait, give blood and LSAs and pregnancy charges studies. Now all of you tell me, I will wait for the lung maturity, and then what do I do? Sir, if only one line I change, sir, I will wait, but wait only till 37 weeks. And once 37 weeks are reached, very good, then you will do LSCS. Now sir, there is no point waiting. बात समझ में आ रहा है? Why? Sir, because after 37 weeks, you are waiting. Suddenly, labor starts, torrential bleeding, mother dead, baby dead. You have gone for a movie, पांच पीछे से patient bleeding start होगा. So why were you waiting for? So don't wait beyond 37 weeks. Is understood, so all of you? So clap if you feel happy. All of you look on the board. एक ही word, एक word change किया. OG in the chat box. ये 33 weeks को मैंने बना दिया 37 weeks. Now what is the answer, all of you? Yes, sir. Only one word change, whole game change. So if it's 37 weeks, answer will be cesarean section. So now there is no point waiting. Is this understood to all of you? Labor induced to kabhi nahi karna hai. So just even one word changes, the whole answer can change. जैसे question exam में आने वाले हैं, you will remember me on the day of the exam. Is it crystal clear to all of you? So I'll make it original question. So there is no confusion. 33 weeks है. Baby is stable, fetal heart rate is normal, mother is also stable, and therefore wait and watch is the answer. Wait and watch is the answer. We will do McAfee and Johnson. Of course, you will give steroids also. Steroids, bed rest, everything will be given. And wait. I would like to wait. Wait till 37 weeks. Wait till 37 weeks. Is it clear? Yes, transfer. Okay. Yes, okay. And cesarean section can be done at around 37 weeks. Okay, because there's no point waiting for or even before. चलो, very again ये MCQ आने वाला है. ये क्या है? Yes sir, this is a uterus balloon. This is a balloon tamponade. Balloon tamponade specifically used. And Bakri balloon, Bakri नाम आपका जब जॉ थोड़ा सा स्टाइलिश, Bakri balloon. Okay, what is the capacity of this balloon? One more MCQ, 500 ml. You push the line. And what is the role of the balloon tamponade? So when the medical management fails, okay, when the medical management fails, and I have to then think of surgical management, in between में आएगा balloon. In between will come balloon. MCQ. PYQ. Okay, balloon tamponade for PPH when the medical management fails and before starting surgical management. Bakri balloon tamponade. Okay, very simple MCQ. Simplest MCQ. क्या है ये? Multiparous patient suddenly starts bleeding heavily after delivery. Uterus is flabby. So it is atonic PPH. In atonic PPH, sir, oxytocin is the first drug of choice. And if the bleeding, or please understand all of the following are one except. Yes, is it clear to accept? Never beta. Chaitanya kachara dustbin. Never vaginal delivery. Never beta. Who said wrong? Never do vaginal delivery. Mother will die to bleeding. Okay. Please see my lecture in detail. Okay, you'll get it. Okay. Misoprostol of course can be used per rectally, vaginally, orally, sublingual also. And carboprost is PGF2 alpha. What is one more MCQ? Absolute contraindication. Misoprostol is PGE1. Okay. Answer is mifepristone. Mifepristone has got no role. No role in PPH. Is it clear? Mifepristone I told you is for MTP. MTP. Is it clear to all of you? Yes. So very important MCQ. Chalo. Now what is the diagnosis over here? When I have a patient who is 2 months amenorrhea, HCG is positive, but ultrasonography uterus empty. What will I think? Yes, okay, sir, when the patient is pregnant and uterus is empty and the beta HCG is positive, look outside the uterus. If the uterus is empty, you will look outside the uterus. Look outside the uterus means what? Yes, and we are seeing a mass 2.5 by 3 centimeter. So you are seeing a mass which is 2.5 by 3 centimeter, which is a ectopic pregnancy. And I am making one more diagnosis. It is unruptured ectopic pregnancy. Why unruptured ectopic pregnancy? Because look at the pulse, BP, hemoglobin, patient is stable. And what is the most suitable modality? So there is no need to do a surgery. Why? You will tell me. And those who wait for 2 weeks will have to go to jail. Why you want to wait? Answer is methotrexate. Why? Can you tell me why? So remember this, okay, for a ectopic pregnancy, always methotrexate is the preferred management. Preferred management specifically for unruptured ectopic pregnancy. Okay. Okay. So there is a mass which is outside the uterus, and uska dimensions are given. And can you tell me the criteria? Yes sir, if the gestational sac is less than 4 centimeters, fetal cardiac activity preferably should be absent. Okay, baby heartbeat should be absent. And what is the HCG levels? Yes, of course the patient should be stable. And lastly sir, the initial HCG should be less than 5,000. Clap. I repeat, if these 4 criterias are satisfied, patient stable, gestational sac less than 4 centimeter, fetal cardiac absent, and its HCG levels HCl level is less than 5000 micro international units per ml. And look at our paper, sir, HCG level 1500. Very good. Patient stable. Look at the size, 2.5 by 3. Don't multiply 2.5 by 3. 2.5 by 3 matlab it is less than 4. Answer is methotrexate. Clear? But now look over here. Sir, here what is the diagnosis? This is a ruptured ectopic pregnancy. Ruptured ectopic pregnancy. Why? Sir, patient is in shock in early pregnancy. 2 months amenorrhea. Patient has come to you with shock. Shock because hemoglobin 6 BP admit. Definitive treatment is what? So in ruptured ectopic, okay, ruptured ectopic, methotrexate cannot be given. And remember, when it is ruptured ectopic, okay, immediately what is immediately to be done? Ruptured ectopic mein immediately, sir, initial management or emergency management. 2 wide bore IV line. 2 wide bore IV line, collect blood for cross match, start IV fluids. This is the initial management. Next, immediately what do I do? And also order for blood transfusion. Okay, basically ABC, airway, breathing, circulation. And what is the definitive treatment? Please understand this. Don't feel sad कि ओ हम पेशेंट का एक ट्यूब कट कर रहे हैं. Another tube is enough to cause population explosion. Okay, remember this. Salpingectomy. Salpingectomy. Get the whole tube out. वो ट्यूब फट चुका है. Okay. Salpingectomy is the gold standard surgery. Is this understood to all of you? And in shock, laparoscopy preferred. So laparotomy and salpingectomy. ये salpingotomy is all kachra, dustbin. You never do it. Salpingotomy नहीं करते हैं. Salpingectomy is the gold standard surgery. Clap. So whenever it is ruptured ectopic, yes, tube निकाल के डाल दो because you cannot save the tube. Quick in, quick out. Quickly enter the abdomen, open up the tube. Because why? Because please understand is that tube is all torn. Okay, that tube is torn. This is the uterus. That tube is all torn and it is bleeding. Okay, that tube has torn. So till the time I clamp the tube and get it out, the bleeding will not stop. Okay. So I have to get the tube out. Is it crystal clear to all of you? Chalo, one more very important MCQ. All are tocolytics except all are tocolytics except. What is the meaning of tocolytics? So tocolytics are uterine relaxants. Uterine relaxants. Ritodrin is a tocolytic agent. Nifedipine is also a tocolytic agent. Magnesium sulfate has tocolytic property. What is atosiban? Chalo, atosiban bata do kya hai? Very important MCQ. कार्बेटोसिन इज द आंसर. क्या है बे? ये क्या है बे? कार्बेटोसिन क्या है? यस सर, कार्बेटोसिन इज उल्टा. इट इज टू मेक द यूट्रस कॉन्ट्रैक्ट. And carbetocin, sir, it is, what is the speciality? It is stable at room temperature. Carbetocin is a oxytocin derivative which is stable at room temperature. It is for prevention. It is for prevention of postpartum hemorrhage. Atosiban is a oxytocin antagonist. It is a oxytocin antagonist. So yes, it is a tocolytic agent. समझ में आ गया? Yes, carbetocin is similar to oxytocin, like oxytocin, but stable at room temperature. Very important short MCQ coming is for prevention of PPH, specifically where cold chain cannot be maintained. Latest guidelines where oxytocin can, because oxytocin needs to be kept in fridge. Oxytocin cold chain requires to be maintained. Is this understood to all of you? Atosiban is also important. Atosiban is a oxytocin antagonist. Don't make a mistake. Very important. Very simple. Amsel's criteria is for diagnosis of bacterial vaginosis. Again, short question hai. Decreased white discharge, I told you. Fishy odor and presence of clue cells. What is the answer? Yes sir, one sign, एक sign चेंज कर दिया, चाइन बट यस जस्ट ओके यस, एक साइन चेंज हो जाएगा. pH is not less than 4.7, pH is more than 4.7. Is this understood to all of you? So just how, see, in the heat of the exam ka tension mein even one sign can change, you will make a mistake. Okay, very important, the most specific anomaly in the baby of the diabetic mother. When the mother has diabetes, what is the specific anomaly? Sir, sacral agenesis, also called as caudal regression syndrome. It is a specific anomaly. Okay, VSD is the most common anomaly. Don't make a mistake. And neural tube defect is the second most common. So, एक पे एक MCQ free. Are you getting my point? एक पे एक question free. The most specific animal baby diabetic mother, sacral agenesis or caudal regression. ठोको ताली, clap. All these are MCQs going to come. VSD is the most common, not the most specific. Is this understood to all of you? And again, a very, very important, match the column. Chalo, if you are there since the beginning, ये बक्खन है, cakewalk है. Okay, it is a revision. Here are the conditions and here are the preferred investigation. What will you do? Anybody? Asherman syndrome is what? Asherman syndrome is a intrauterine adhesions. And Asherman syndrome, anybody? Will I do hysteroscopy or laparoscopy? Yes, sir. Sir, Asherman syndrome is intrauterine adhesions and they will require to do a hysteroscopy. Very, very important. Yes. So, Asherman syndrome 2A. 2A. So 2A. So if it is 2A, this is 2A, this is 2A. ये 2B नहीं है. Asherman will not. So this is out. This is also out. Okay. Now, endometriosis, I just now told you, endometriosis requires laparoscopy. 1B. 1B, yes, 1B, 1B, 1B. ओके, तो अभी तक दो माइंड में चल रहा है, 1B 2A. वाई एंडोमेट्रियोसिस? चलो रिवीजन. लैप्रोस्कोपी में क्या होगा? यस सर, फ्रूट्स, टेरेस व्यू. सर, व्हेन आई पुट इन द टेलीस्कोप फ्रॉम अबाव endometriosis, we will see the adhesions between the tube and the ovary, chocolate cyst, and we will get all this powder burnt spot, black spots I have drawn today and shown you. And also do not forget, we get this blue spots and red raspberry. So your remember this, okay, endometriosis requires laparoscopy. Now whenever there is a torsion, color Doppler, very good, 3C. Why color Doppler? Because the torsion is around the pedicle. The pedicle say the ovary gets twisted. And what will I see? Anybody? What will we see if it's a torsion? Torsion के लिए MCQ बहुत important है. They will tell you acute abdomen. They'll tell you large ovarian mass, severe abdominal pain. And torsion में क्या होगा? चलो tell me. Yes, sir. When the pedicle will get twisted, the blood supply will get occluded, and you will see absent flow. The blood supply, and therefore this organ can undergo necrosis. Is it clear? And therefore ovarian torsion 3C, and therefore you have the answer. And adenomyosis, we do normally ultrasonography, 4D. Is it clear to all of you? So 3D nahi hai. Yes, the very good. Those who said C is the answer. C is the answer. Crystal clear to all of you. Okay. 3D nahi hai. 3D nahi hai. 3 के लिए you require color Doppler. तो ये out है. Okay. 1A नहीं है तो ये भी out है. And C is the answer. Yes, because whenever there is a twisted pedicle, the blood flow will be absent flow. Keep that in mind. Is this understood to all of you? So torsion के लिए color Doppler is the investigation of choice for torsion. Very important, again a PYQ. Okay, so match the column is a new style of asking question. Whenever you get such kind of questions, don't panic, you will get it correct. Is this understood to all of you? And my dear student, look at this beauty. I'm telling you, still there are students who have told me, sir, after the first paper was over, in the break time there's a notes read along. Just in 2 hours you can read the entire colorful note, is my guarantee. Even if you don't want to read the note, just please enroll in this OBG score booster. So final chance. We had 3 sessions live, we had already conducted. Iska recordings you are getting. You can revise the whole OBGY just in 4 hours. In 4 hours, and just in 199. Download the OGGuru app quickly. You are going to get 3 sessions of 2 hours each. It is 6 hours program which you can easily finish in 4 hours by seeing it at 1.5x speed. All the important images will be there, all the clinical MCQs will be covered, and all the expected MCQs are going to be covered. So if this 2 hour session has benefited you, you imagine if another like this, 3 more sessions of totally 2 hours, which you can say 1.5. So 6 more hours of content if you do, and you can finish off tomorrow only. Tomorrow, day after tomorrow, every day also. If you do 2 hours just in 2 days, it will be over. So please don't miss out on this opportunity. Of course, I'm available for you on phone and WhatsApp on this number. Download the OGGuru app. And this, my dear students, same thing will happen with all of you. These are the messages which I get on WhatsApp every day. And same thing when you will walk out of FMGE examination, you will, sir, each and every question came from directly what you had taught us. Same thing, sir, the best OGGuru app. Once again, thank you. First attempt, I got it cleared. Sir, I carry the lessons beyond the classroom, sir. Everything. Second part, OBGY was the game changer. That will be happening to all of you. OBGY will become the game changer. So no words to express. Same thing, you will message me, my dear student. These all messages you can read. And very, very important, FMGE. Please keep the faith in your God and in your own abilities. Stay absolutely motivated. Don't get disheartened. Okay, pressure आएगा, tension आएगा. Don't worry. Absolutely stay motivated के पास होना है. And lots of efforts you are going to put in the last 7 to 8 days, and do not miss out on the guts. So faith, FMGE, and all of you will be clearing the exams. Don't worry, I'm always available, and any doubts you can message me or WhatsApp me or even call me. Okay, FMG, here's wishing you all the best, and please do not forget to subscribe to the YouTube channel. Lots of important content is there. Images MCQ, new pattern MCQ, and I'm also going to put up one last day list of important OBGY topics prediction which I do every year, and the exam day management. Of course, once the Telegram span will be lifted up in few days time, this whole PDF I will upload on the Telegram. So please follow on Telegram, and do not forget to follow on Instagram. Just take 2 seconds of your time, open the app, open your phone, and quickly, beta, already, yes, beta, all new updates are added, beta. Okay, salam, beta, already added in the app. Already all the recent advances already added in the app. Okay, all the PPH guide and all the recent things are added in the app, and all of you have, all my students have already seen it. Is it clear to all of you? And please subscribe to the YouTube channel and get in touch with me on phone and WhatsApp on this number. And finally, do not forget to enroll in this OBG booster course. Just 199, life changing thing. Your tremendous score in OBG is going to boost it up from 10, 11, 12 to 25, 27, 28. 30 to 32 questions will be coming in the FMG examination. So here's wishing you all the best for all the examinations. Bye bye, best of luck. Thank you very much. OG in the chat box, please tell all your friends and colleagues also about this app and also about this session. Share this video with all your friends. I hope all of you had a great time. Best of luck. Last thing, please read the question correctly. क्वेश्चन पढ़ने में मिस्टेक मत करना. मिस्टेक स्टूडेंट्स आर मेकिंग इज दे आर नॉट एबल टू रीड द क्वेश्चन. Okay, they are not reading the question correctly. So in the whole I have shown you today, read the whole question, specifically in obstetrics. Baby heart rate, how much? Mother condition, how many weeks of gestation? Whole thing depends on weeks. So please look at the weeks also and then decide. Is this understood to all of you? So here's wishing you all the best. Bye bye, best of luck, and thank you very much. And all of you will do very well, is my guarantee. Best of luck for the exam.